You should definitely subscribe to evidence-based cardiology talks.
Where can people find it?
They're on Spotify and YouTube. Seriously, if you want those expert takes on the newest research, you won't want to miss it.
Good tip. Okay, so speaking of expert discussions and papers, the one we're actually diving into today was featured on evidence-based cardiology talks.
What's the title?
It's Ischemia and Anatomy in the new 2024 European Guidelines for Chronic Coronary Syndromes. Update and comparison of recommendations.
Okay, quite a mouthful. Who's the author?
It's by Christian A. Caroli, published in the Journal of the Saudi Heart Association.
Got it.
And for anyone wanting to read it themselves, it's manuscript 1416, available over at jsat-saudi-heart.com. It's under a Creative Commons license.
Great. So, okay, let's get into this paper then. What's our mission for today's deep dive?
Right. We want to really understand the key updates from these 2024 European Guidelines for Chronic Coronary Syndromes, or CCS, specifically through the lens of this paper.
Focusing on ischemia and anatomy, like the title says.
Exactly. How are the guidelines approaching ischemia testing, functional tests versus anatomical testing? And how does it all compare to, say, the American guidelines?
And this is a big deal because it brings in learnings from that huge ischemia trial.
Precisely. That trial really influenced things.
Okay, so where does the paper suggest these new European guidelines start? What's the first step?
It seems the big shift is right at the beginning with risk assessment. They've introduced something called the Risk Factor Weighted Clinical Likelihood Model, RFCL for short.
RFCL. Okay, so what does that involve?
Well, it means the very first step is a more structured look at the patient's clinical picture and their risk factors to estimate the probability of them having coronary artery disease.
Right. And this model, the RFCL, it considers things like, well, the basics, age, sex, the type of symptoms they have.
Like chest pain, yeah.
And then those key risk factors, we always look at family history, smoking, cholesterol, blood pressure, diabetes.
So it pulls all that together initially.
Yeah, and the paper points out that this first step can actually be pretty good at identifying people who are at very low risk.
Which could mean less testing for some people right off the bat.
Potentially, yeah.
Yeah.
Streamlining things for that very low risk group
Yeah.
seems like a real shift.
Okay, but it's not just that initial score, is it? I think the paper mentioned something about layering on risk enhancers.
That's a really important point, yes. After the initial RFCL calculation, you look for these enhancers.
Like what sort of things?
Things like changes on a resting ECG, maybe an abnormal previous stress test, signs of LV dysfunction or arrhythmias,
Okay.
peripheral artery disease, or even if they know there is coronary calcium from a past CT scan. You really only classify someone as higher risk if they have that initial RFCL plus at least one of these enhancers.
Got it. So RFCL first, then check for enhancers. That clarifies the initial risk. Now, how does this risk level then guide the decision on, say, functional testing, the test looking for ischemia?
Right. The paper explains the guideline recommendations based on that RFCL category. For the very low-risk folks, testing generally isn't recommended.
Makes sense.
In the low-risk group, it's a bit less clear-cut. The guidelines suggest maybe considering a coronary artery calcium score, CCS.
To potentially downgrade them to very low risk.
Exactly. Or, interestingly, for these low-risk patients who still have symptoms, the recommendation is actually CCTA.
The CT coronary angiogram. Let's look at the anatomy.
Yes. To rule out blockages.
Yeah.
Because CCTA has that really high negative predictive value. It's great at saying, nope, no significant disease here. Functional studies aren't really the first choice at this low-risk stage.
Huh. That is interesting. Prioritizing the anatomical CCTA for symptomatic low-risk patients before functional tests. Okay, what about the moderate and high-risk groups from the RFCL?
For moderate risk, the paper says the guidelines basically put functional studies and CCTA on equal footing as initial options.
So a choice there.
Yeah, depends on the patient, what tech is available locally, team expertise, cost, even patient preference.
Yeah.
Lots of factors.
Right.
The guidelines also mention possibly using CCS in this moderate group, especially if you have access to more advanced imaging like SPECT-CT or PET-CT.
Okay. And then high risk.
For high-risk patients, the recommendation shifts mainly to functional studies first. CCTA is not recommended as the initial step there.
So functional tests come back to the forefront for high risk. What about the very highest risk, like someone with really severe symptoms?
Yeah, for those with a very high RFCL, think angina, with minimal effort, severe LV dysfunction, dangerous arrhythmias, blood pressure dropping during exercise.
Really concerning signs.
Exactly. The guidelines say move straight to invasive coronary angiography, maybe with physiological assessment like FFR during the procedure.
Okay, so functional testing as an initial non-invasive step is really focused on that moderate to high-risk range based on the RFCL.
That seems to be the main takeaway, yes.
Now, you mentioned the ischemia trial earlier. The paper digs into that, right? How did ischemia influence this approach?
It definitely did. Ischemia and even earlier trials like Courage and Berry 2D, they suggested something important. In patients with preserved ejection fraction.
A good heart pump function.
Right. In those patients, just finding myocardial ischemia on a test might not be the strongest predictor of bad outcomes by itself.
Meaning?
Meaning that doing revascularization like stents or bypass, based only on that ischemia finding, didn't necessarily lead to better outcomes compared to just managing them with optimal medical therapy.
Okay.
So that evidence seems to have pushed the European guidelines towards using functional testing more strategically, really targeting it based on that initial RFCL risk, not just testing everyone.
Be more selective. Okay, let's pivot to the anatomy side then, CCTA. The paper calls its rise a remarkable revolution. What's the thinking there in the 2024 guidelines?
Well, the new guidelines give a strong thumbs up to using CCTA as a first-line test, but specifically in patients who fall into the low to moderate pretest probability range using that RFCL model.
Low to moderate risk again. Why the strong recommendation there?
Again, it comes back to that high negative predictive value. It's excellent for ruling out coronary artery disease in that group, so it's recommended both for diagnosis and for helping estimate future risk.
But crucially, not for the high or very high-risk groups as the initial test.
That's what the European guidelines say, yes, which, as the paper notes, is a bit different from some American guidelines.
We'll come back to that comparison. The paper also mentioned FFRCT. That sounds like a hybrid?
Kind of. It's coronary CT, angiography-derived fractional flow reserve.
Yeah.
And yeah, it's included for the first time in the European guidelines.
What's its role?
It's specifically recommended to help figure out the significance of blockages that look like they're 70% or more, particularly in the proximal LAD artery, a really important vessel.
And how does it work?
It uses fancy computer modeling on the standard CT images to estimate blood flow pressure differences across the blockage.
So anatomy from the CT plus a functional estimate without needing drugs or wires.
Exactly. It combines both. And the paper notes that an FFRCT value below 0.8 is strongly linked to worse outcomes.
Interesting tech. Now, the author of this paper, Dr. Caroli, he seems to suggest CCTA could maybe be used even more broadly.
He does raise that point, yeah. He questions if the recommendation shouldn't potentially span the whole RFCL spectrum, maybe even as an alternative to going straight to invasive angiography in some high and very high-risk cases.
So pushing the envelope a bit beyond the current guideline recommendation.
While he's highlighting the growing evidence, studies like PROMISE and Scott Hart, which the paper mentions, show that using CCTA to guide management can actually improve outcomes, fewer deaths, and heart attacks.
Wow.
Potentially by spotting high-risk anatomy earlier, getting patients on the right medical therapies sooner, and maybe even helping patients stick to their treatment better.
And it doesn't necessarily lead to more invasive procedures down the line.
Actually, the evidence suggests it might reduce the need for future invasive procedures, contrary to some early worries. It's becoming a really well-validated tool.
It definitely sounds like CCTA is becoming central. The paper even mentioned newer CT tech on the horizon.
Yeah, things like photon counting CT and ultra-high spatial resolution CT. The 2024 guidelines haven't fully integrated them yet. It's still early days.
But the potential is there.
Huge potential, according to the paper.
Yeah.
Better tissue detail, more accurate blockage assessment, even looking inside existing stents better. Early research suggests they could boost accuracy even more.
Maybe fewer invasive caths needed in the future.
That's the hope. Yeah.
Okay, so let's try to pull this all together. Based on Dr. Caroli's analysis in this paper, what are the headline shifts in the 2024 European CCS guidelines?
Well, number one has to be the introduction of that risk factor-weighted clinical likelihood, the RFCL model, for initial assessment. That's fundamental.
Right.
Second, there's this clearer, more nuanced role for both functional testing and anatomical testing, mainly CCTA, and it's really tied to that initial risk stratification.
So functional tests are still key for moderate to high risk.
Absolutely. But CCTA gets that strong recommendation for the low to moderate risk groups.
And how does this stack up against the U.S. guidelines? What are the key differences the paper highlighted?
There are a few distinctions. For instance, the paper notes American guidelines might consider CCTA even in high pretest probability patients, whereas the European ones largely keep it for low to moderate risk initially.
Okay.
And maybe the exercise ECG has a slightly stronger emphasis in the U.S. guidelines, even for higher-risk patients, while the European ones seem to suggest it's less needed if you have CCTA or functional imaging available.
But overall, big clashes or mostly aligned?
The paper's conclusion is actually that there's more agreement than disagreement overall between the two sets of guidelines.
So the underlying trend is similar.
It seems so. The paper suggests we're moving towards a more integrated approach everywhere, combining anatomical and functional information. Functional studies are still vital for guiding treatment.
But CCTA, especially with additions like FFRCT or maybe CT perfusion down the line, is playing an increasingly important role.
Exactly. Towards more precise, personalized management for chronic coronary syndromes.
So for our listeners, particularly cardiologists tuning in, what's the bottom line here from this deep dive?
I think it's that these new European guidelines, as broken down in Dr. Caroli's paper, offer a really fresh, evidence-based framework for assessing risk and using ischemia and anatomical tests. It's a
Yeah.
crucial update.
Especially with the ischemia trial's impact and all the CCTA advancements.
Definitely. And it prompts a really interesting question to think about, doesn't it?
Go on.
Well, the paper mentioned those cutting-edge CT technologies like photon counting CT that aren't fully in the guidelines yet.
Right.
So the question is, how might future guidelines evolve? How will this interplay between looking at the anatomy and looking at the function change further as these technologies become mainstream?
How will we balance the pictures from CCTA with the physiology from functional tests even more effectively in, say, 5 or 10 years?
Exactly. It's worth reading the paper and really thinking about how these ongoing tech developments might shape practice.
That's definitely some important food for thought. Well, thanks for joining us for this deep dive into Dr. Caroli's analysis of the new European CCS guidelines.